we go.
Great. Okay. Can everyone see the slides?
Yes.
Yes, perfect. Okay. I'm going to try to minimize myself so I don't have to look at myself. Okay, so what causes psychosocial distress in survivors, and why should we bother to pay attention to it and screen for it? So this is a little blurb taken out of the pretty famous at this point Institute of Medicine report about the state of cancer care in the United States. I think the original one was done in the early 2000s, and there have been, future iterations of it as well. I think this is taken from the 2007 edit of this report. And I'll just go ahead and read it and highlight a few things. So, as we all know, cancer care today, we have made a lot of advances, and we are able to provide state-of-the-art biomedical treatment. But that treatment, unfortunately, does fail to address the psychological and social, aka psychosocial problems associated with the cancer experience. And this failure can certainly compromise the effectiveness of the healthcare that many of you provide, and therefore, adversely affect the health and overall survivorship of our cancer patients. The psychological and social problems created or exacerbated by the cancer diagnosis and treatment can range for a lot of different things, including common things that we might think about, such as depression or other emotional problems like anxiety, certainly lack of information or skills, which we call coping skills, needed to manage the illness and the different life problems that it may bring up for folks. A lack of transportation, certainly we see a lot of at U of I, and other basic resources that folks need to be able to live in their day-to-day experience and be able to also at the same time engage in treatment with us. As well as disruptions in work, school, family life. All of these can certainly create additional suffering. And then, of the fact that they do weaken adherence to prescribed treatments. And thus, this overall certainly results in threats to the patient's return to health. So we definitely need to pay attention to this. Another reason why we should pay attention is that managing psychosocial distress is actually required by the Commission on Cancer. In order to be certified as a cancer center, we do actually have to make available resources such as social workers to patients to be able to treat the psychosocial components of the cancer experience. And this is taken from the previous iteration of the COC survivorship recommendations, but it's now currently standard 5.2, but I thought that standard 3.2 sort of summed it up nicely. So it's, again, just emphasizing the importance of screening for and addressing psychosocial distress in survivors. And it goes over some of the similar things here, but psychological, social, financial, behavioral issues that can interfere with someone's treatment plan and overall outcomes. So I wanted to briefly touch, before we move into some of the primary areas of distress, how we screen for distress in survivors. And there's a couple of different formats in which we can do this. There are actually a lot of well-researched and validated tools that we can use as clinicians. Anyone can use them, really. Certainly these are my wheelhouse and any social worker's wheelhouse, but anyone can use them. They're pretty user-friendly. The NCCN distress thermometer is a common one. We at UIH use the Coleman Comprehensive Distress Screening Form, which is a multidisciplinary tool that I really like using. The patient health questionnaires, whether it's the PHQ-2, 4, 9, any of those, or the HAD scale, any psychological measure that can pick up on things like anxiety and depression, things like that. The Edmonton Symptom Assessment Scale, which again, is used in palliative care, in OT-PT, and in various disciplines. That's something that shows up. as well as the Promise tool. And then for folks experiencing maybe an acute psychiatric complication from their cancer diagnosis or treatment, the Columbia Suicide Severity Rating Scale is a good go-to as well. So those are some of the formal tools. And then also a clinical interview by a social worker where we are going to be touching on, a lot of areas of someone's life is certainly a very good standard as well to go ahead and screen for someone's distress. And then two, a lot of our patients are actually really good about reporting some of their stressors that they're experiencing, whether this is something that they were already experiencing prior to their cancer diagnosis and treatment, or something that can come up along the way. So we also rely a lot on patient self-report. And as you all probably know in your work, patients will report this to any number of staff members on their medical treatment team. And so it's important then, and here at UI Health, I feel folks are very good about relaying that information to the social work team so that we can follow up with the patients and families. So now we'll move into some of the primary areas of distress. And these are all, again, taken out of the Institute of Medicine report. There's a lot of, research documenting this. So this is certainly not something that I'm just pulling out of thin air, but I will say that, my experience working in oncology definitely, I think, validates and overlaps with a lot of these areas. And I can attest that these are pretty accurate. So the first broad category is health impairment and disability, disability in a lot of different senses, including things like fatigue and pain. And so what happens when someone is experiencing this, they're likely going to have poor health overall for the remainder of the lifespan. And I think we see this certainly is true in the populations that we work with who are already experiencing some health equity issues. And then this just sets them up for additional potential long-term complications from treatment and future health problems as well. Certainly the diminished quality of life is something that we see and something that we want to try to screen for. Long-lasting cognitive impairments can really become an issue. We all know the chemo brain sort of suite of symptoms with problems in memory, concentration, processing, abstract reasoning and thinking, problem solving, and a lot of times these do go away once their chemotherapy treatment is finished, but not all the time. And even subtle changes in someone's cognition can really have a ripple effect. I forget what I was reading, maybe it was the New York Times, but there was an article where they actually interviewed a surgeon who had to go through cancer treatment. And she just had the slightest cognitive changes that continued past her treatment. And she actually had to stop operating because she couldn't, keep up safely in the operating room. So even small changes can have a huge impact for folks. Another area of distress in this space is the decreased physical ability to perform, activities of daily living. Whether this is someone had to have their leg amputated, and so now they have to learn to walk with a prosthetic, or someone has a lot of neuropathy, and so they're unsafe in their home. We see this a lot with older folks and falls. The ability to bathe yourself, the ability to cook for yourself, these can be short-lived during the treatment, but they can also last long into survivorship as well. And that can, again, really impact someone's ability to function and their ability to function in their family unit like they did before. Again, we see more impacts in the family system with difficulty parenting or caregiving, whether it is a physical limitation, an emotional limitation, a psychological limitation. It's a significant stressor for someone to try to manage and be present in the way that they would like to be for their children or their spouse or their elderly parent that they're caregiving for. That's a lot to try to juggle. Health impairment can certainly impact someone's ability to work, period, or full time, like they may have been used to, or in their chosen field, sort of like the example of the surgeon that I had mentioned. This person had to switch areas of work after, dedicating a lot of their life to practicing in one specific area. And that can be really difficult to adjust to, especially psychologically. School becomes more challenging for our pediatric and AYA populations. So that's definitely something that we need to, pay attention to and intervene on so that our AYA populations don't fall behind in their learning, because this can obviously impact someone's life trajectory, as well as their development. And of course, any change in ability to work certainly will then trigger things like financial stressors, or if you feel like you're unable to work in the same capacity that you were before, you just have less life satisfaction and less meaning found in your work. So again, these can really sort of have ripple effects long into the future. The next primary area of distress is emotional health, mental health, and associated developmental problems. There's a lot of research documenting the increased prevalence of mental health diagnoses in the cancer population. On any given day in America, approximately 20% of folks might be experiencing a mental health diagnosis, but this actually doubles. And in our population, who is already predisposed to a lot of trauma, a lot of pre-existing mental health conditions, it can sometimes be 3 or 4-fold, what the average risk of a mental health complication is. So this is really, really something we need to pay close attention to. Some of the most common mental health concerns in survivors are depression, anxiety, adjustment disorder. There's more and more emerging evidence that PTSD, both in the subclinical and clinical categories, is really showing up in our cancer patients, both during treatment and then after treatment as well. And again, as I mentioned, our patients have a much higher risk profile compared to the average cancer patient as well. And even if someone isn't going to be diagnosed with a formal mental health condition during or after their cancer treatment, they're going to experience some level of what we call global emotional distress. And these are sort of universally felt, common, but still distressing subclinical feelings of things like loss, guilt, anger, sadness, confusion, worry, certainly body image, if you're experiencing any level of disfigurement from any of your treatments. Even something like losing your hair can be really distressing for folks. It comes with isolation, generalized stress, and obviously the pandemic has exacerbated all of these categories as well. So people are feeling a lot of additional distress these days. Another related area is spiritual distress in their experience. We sometimes refer to this as existential or moral distress, and it's actually associated with an increase in whether it's active or passive, but suicidal ideation, or sometimes what we call a desire for hastened death. This can also trigger feelings of hopelessness, despair, and other psychosomatic symptoms, that may present in a very physical sense. And so that's something, that we want to try to address for patients. For a lot of our patients, their religion, their spirituality is a source of coping and strength, or it had been up until their cancer diagnosis. And now they are very troubled by this happening to them. Everyone thinks it's never going to happen to me, and then it does. And that brings up a lot of questions about justice and your belief system. And so, a large coping mechanism may be temporarily removed from your coping toolkit. So we definitely want to address that with folks. And then finally, we do have some psychological developmental delays that we see associated with cancer survivors. This can impact someone's delay in developing mastery, whether it is in school or, sort of moving on in their life. If they are in a job where they are learning new things, this can sort of delay or stall that. Their identity is certainly impacted. How we relate to our physical selves is a big part of our identity. And if all of a sudden we're not able to trust our bodies, that can really have an impact on their psychology. Certainly their social roles are changed. You may be, married to someone for 10, 15, 20 years and you are partners, you know each other as spouses, and then all of a sudden you have to switch to this mindset of being a caregiver and a patient. And that can be a really challenging dynamic, both to switch to that and then, hopefully if someone has curative intent in their treatment and all goes well, it could actually be really difficult for folks to switch back to their previous roles and get out of that patient and caregiver sort of mindset. In children, we will often see regression, in terms of their developmental milestones when they're going through cancer treatment. And so we see that associated in our survivors as well. And then, obviously, if you are going through cancer treatment as an AYA, some of the treatment itself, whether it's radiation, chemotherapy, what have you, these can cause physical developmental delays, whether it's related to, hormones that they are experiencing or being given, or other things like that. So definitely can have a physical impact as well. This is just a brief reminder for everybody, although I'm sure that this is your lived experience as well. But our patients here at UI Health experience a lot of compounded risk for a lot of these areas of distress. A lot of folks have pre-existing rates of mental illness. They have generalized trauma exposure, specifically to neighborhood violence and poverty as well. And that can set someone up to be unable to cope with a cancer diagnosis and treatment, as well as someone who doesn't already have these pre-existing risk factors. So another area of distress that we do want to pay attention to is distress in the family or caregiver system. I found it alarming that caregivers of chronically ill folks actually live on average 4 to 8 years less than someone who is not in a caregiver role. And this is actually due to physical changes in the body associated with chronic stress, which leads to chronic inflammation, which can actually shorten the telomeres, leading to weaker immune system functioning, and add that in that they are neglecting their own physical health care. They're not going to their doctor's appointments because they're taking care of someone else. Their mental health is suffering because of all of the stress, all the emotional challenges, and all of this can ultimately result in an early death. So we also want to make sure that we're supporting, the family systems and the caregiver systems that our survivors have in place. And then, of course, caregiving can lead to what we sometimes experience in healthcare, but the phenomenon known as burnout. And this can actually, in some folks, lead to not only neglect of self, which we've already touched on, but also of the patient or other family members. And that can further complicate someone's, cancer experience, their ability to comply with treatment, all of these different things. So we want to make sure that the people who are, day to day taking care of our survivors at home are also supported and their needs are addressed. So I wanted to touch a little bit also in the primary areas of distress, how these sort of overlap with some of the social determinants of health that we find in the literature as well. So any of disruptions in any of these areas can certainly result in a complicated experience or an inability to cope with and comply with treatment. Whether someone is or underemployed coming into their cancer experience can certainly set them up for, immediate impacts on their financial situation, their housing, all these different things. Their level of education and health literacy, someone who has only a first grade reading level or first grade level of health literacy is probably going to struggle more than someone who has a higher level in terms of understanding sort of the gravity of what is happening. And then also, every time that they're hospitalized and they have to read their discharge instructions or, manage the logistics of a complicated radiation and chemo schedule, all of these things can be really, really challenging. And if they don't understand, details about their diagnosis, what their treatment plan is going to be, it can really impact their desire to comply and their ability to comply as well. Someone's socioeconomic status, their income level, obviously can impact their ability to sort of be resilient in the face of a cancer diagnosis and treatment. And there's actually interesting research out there about the trauma of poverty, especially growing up in poverty, and how it can impact your brain and your ability to engage in future planning. Um, I think we see this sometimes where folks are really in a day-to-day mindset and they will frequently forget to plan ahead, whether it's, take time off work or have paperwork filled out in an appropriate amount of time or remember to book their transportation. This can really impact someone's ability to comply with their cancer care, because you do have to think both short-term and long-term in order to be successful. Substance abuse or misuse of different kinds of substances certainly can get in the way of someone being able to successfully engage in their cancer treatment. Whether someone already was in the throes of a substance use disorder and therefore really has trouble onboarding into the treatment process, or whether they've been sober for a long time, but the significant stressor of a cancer diagnosis and treatment can really trigger a relapse of that substance use disorder for them. So that's something we need to be paying attention to, because, a lot of folks will use drugs or alcohol or other kinds of things to numb the emotional pain of what they're going through. So we definitely have to be aware of that. The quality of someone's social ties really, really can impact their cancer experience. We typically see in our lived experience and in the literature that folks who have really robust support systems do a lot better in terms of their compliance with their treatment, but also their overall level of happiness and satisfaction throughout the cancer experience during treatment and far, far into survivorship as well. So someone who is socially isolated, is used to relying on themselves, all of a sudden they can't do that for any number of reasons, including physical disability. They're going to struggle to be able to sort of keep it all together and engage in treatment. We see a lot of food insecurity in the UI health population, and that can really impact someone's ability to take care of themselves, get adequate protein for surgical recovery. All these kinds of things can really have a direct impact on their cancer treatment. Their physical and environmental safety is certainly an area of concern here. Housing is a chronic issue, not only here in Chicago, but nationally in the United States. And again, being tied to someone's ability to work, to manage their finances, someone often will have to maybe choose between paying their rent or their mortgage or paying a copay or a medical bill. And oftentimes, folks will sometimes choose to not pay rent or mortgage because they have to make that really tough decision, and then they become at risk of being homeless. And so we really want to be proactive and help folks manage that. Certainly domestic violence and community violence is something that shows up as a social determinant of health, both in terms of prior or current trauma exposure. And then also, if you're experiencing domestic violence in your home, that's not, your cancer diagnosis is maybe not going to be the primary thing that you're focused on. You're focused on staying alive or protecting your children or all of these different things. So we want to make sure that we are assessing for that risk factor. Again, access to healthcare. Obviously, we see this in our patients who, have lower health literacy, don't have a clinic that they're associated with, maybe don't have health insurance to begin with. And so they are ignoring these, what we would consider concerning symptoms of a potential cancer diagnosis for months, for weeks, for years at some point in time. And so they're being diagnosed at a later stage than maybe if someone had been regularly seeking primary care. Certainly in some populations that we serve, there's a general lack of trust in institutions, including the medical system. I think we're hopefully all familiar with some of the ways that Black and brown bodies have been exploited in the past for medical research. And that still is a very lived experience, particularly in older generations, but that is passed down certainly to younger generations and communities of color. And so that's something we really need to pay attention to. Someone's language and culture can really impact their cancer experience. Again, thinking about if you speak Cantonese and all of your discharge instructions are printed in English and you don't have someone in the home who can readily translate that for you, even if we, take the steps that we need to in terms of using a translator and, explaining things, when someone walks out the door and then has to refer back to this sheet in English, that can really impact their ability to take the correct medication dosage or come at the right time for their follow-up appointment, despite our best efforts. And then, different cultures view disease and cancer in different ways. And sometimes people's culture may indicate that this is something to be ashamed of and that they should not talk about. And so they keep it to themselves. Whereas maybe if they had shared, they would have been able to engage in a lot of social support, but instead they're keeping it to themselves, and that makes it more difficult to comply with their cancer treatment. And certainly someone's legal status, thinking about the fact that there are a lot of undocumented folks, certainly here in Chicago, that come down with that experience cancer diagnosis and need treatment. And again, someone's legal status has their impact in all of these other areas of social determinants of health. And so that can, again, prevent someone from seeking treatment, impact their access to treatment. They're not going to have workplace benefits like FMLA or disability. So they're really going to struggle to be able to get through their cancer treatment because they don't have these sort of safety nets that they can always rely on. So I wanted to transition a little bit to what we can sort of do to address these social determinants of health broadly, and then these specific areas of distress in our cancer survivors. And I learned this when I was putting together this presentation, but approximately 70% of health and factors that influence someone's health actually occur outside the healthcare system, in the psychosocial environment. So we really need to remember that when we are developing a care plan for someone, we really need to treat the whole person in order to be successful as providers and set a patient and family system up for success in their cancer diagnosis and treatment. And as we know, UI Health is certainly committed to health equity at its core. And I thought it was a decent analogy to present to you, but try to think of social workers like myself and many of my colleagues as sort of doctors of health equity. Instead of diagnosing the cancer or the disease, we diagnose some of these barriers of care. Instead of prescribing medications, we are prescribing community resources that will hopefully alleviate a lot of these social determinants of health. And instead of performing surgeries, we perform supportive interventions to remove psychosocial dysfunction and try to heal that mind-body connection and that community connection so folks can be successful. So these are some of the ways that you all as providers can integrate social work to alleviate distress in survivors. These are some of the core services that we as social workers can provide and you can refer patients to receive. So we'll just go through some of them right here. Care coordination and medical case management, we're able to provide, whether it is referrals for occupational therapy, physical therapy, palliative care, setting up help in the home, whether it's a nurse or a homemaker, we can certainly set people up with these services to build a support system for them, as well as generate a basic comprehensive psychosocial care plan, based on a distress screening or a clinical interview. We can sort of touch on all of the global areas of distress and figure out, does somebody need an intervention in this area, or are they doing okay for now? And that plan can obviously change over time. If someone is experiencing acute psychological reactions, we are able to do suicide assessments and safety planning, and encourage folks to seek mental health treatment to support them through their cancer diagnosis and treatment experience. We can help with advanced care planning and goals of care counseling. We often don't want to talk about these things. And patients sometimes will avoid these conversations, but they're really, really important, in thinking about future planning and planning ahead. We want to make sure that people are thinking clearly and that their desires for if they should end up in an end of life situation, that, it's meaningful to them and it goes the way that they want it to go. So we definitely can help with that. Obviously, we help with referrals to community resources to meet some of these very basic needs, like food pantries, if someone is experiencing homelessness or is at risk of that, housing resources, job training is one I think that not a lot of people think about, and that can be during the acute phase of treatment, or it can be afterwards. If someone knows right away that they're not going to be able to work in construction anymore, they can start to think about, okay, well, if this is the only skill set that I have, maybe I need to seek some additional training to become an administrative assistant, or, any other number of careers. We can help folks connect with job training resources. If someone loses their job and doesn't qualify for disability or has any workplace benefits, like a short-term disability policy, we can connect them with some of these basic state and federal programs through the Social Security Administration, like the supplemental income program, so that they can have a basic income, so they can keep up with paying for groceries, paying for rent, these kinds of things. And then transportation too. Luckily our Medicaid system does include transportation as a benefit, so educating folks about how to use that. And then there are also some other options that we're able to connect folks with as well, so they can physically get to their appointments. Certainly, we are able to provide referrals to specialized oncology resources, such as support groups, caregiver resources, again, to address and prevent things like burnout, coping skills classes. If this is someone's first major life crisis or medical crisis, we can't expect them necessarily to know how to cope with a significant stressor like this. And so sometimes we just need to teach people, some new coping skills so that they can be successful, and it can reduce their overall level of distress or the burden that they feel from their cancer diagnosis and their treatment. We're able to provide psychoeducation on different areas of patients' rights, relevant laws that might be applicable to any of the social determinants of health that they might be interacting with. Some common examples would be FMLA, the Family Medical Leave Act, and other job-related leaves or laws that they would need to enact to protect their job, protect their health insurance status, all these different things. Social Security disability, obviously, is a big one. If you're unable to work for at least 6 months, often a year or more, you may qualify for income recovery through the Social Security Administration. So we want to be encouraging folks and also providing navigation and sort of realistic expectations about what that process might look like. Again, substance abuse screening, and if that is an issue for someone, we can give them treatment referrals so that they can heal in that and then no longer have it be a barrier to treatment compliance. Again, screening for domestic violence, and if someone is experiencing that, making sure that as quickly as possible, we're coming up with a safety plan, whether it's them leaving and going to a domestic violence shelter or moving in with other family or friends. We really want to remove that very acute and immediate physical safety threat for them. We can assist with shelter placements for folks who are actively experiencing homelessness, and then really work pretty aggressively to try to connect
just
them.
wanted to let you know they're on their way to.
Oh, Zaida, I think you're need to mute yourself. Thank you. Yep. So shelter placements for undomiciled folks. And then try to connect them with longer term housing resources as well. Because obviously we know that, shelters are not an ideal place for a cancer patient to be. It's good that they exist so that they're not on the street, but there's still risk of infection, risk of violence, all these different things. So we want to get them in and then try to move them on as quickly as possible. We can certainly set up home hospice for folks, or educate them on things like palliative care, and the difference between palliative care and hospice care, so that they're informed about, their treatment decisions and what their options might be, and when they may want to, if their disease has progressed or their prognosis is not good, help them think about, okay, if this is the time that I have left, how do I want to spend it? When do I want to transition to hospice? All those different things, which can be really difficult and ongoing conversations. So we're definitely able to help with that. General patient advocacy, whether it be advocating for a patient's, to their insurance company, if they feel like they're not communicating well with their medical team, we can sort of step in and help to improve communication between those parties. And then certainly, for ethics consultations, if someone is experiencing a legal problem, or maybe DCFS is involved in the family system for some reason, or someone is no longer decisional or is intermittently decisional, and it really becomes a question of, are they making decisions in their own best interest? Do we need to think about getting a guardian in place? All these different things we can provide some advice to medical teams and to patients and families on. And then certainly if someone would need like a bone marrow transplant or a solid organ transplant due to their cancer diagnosis or treatment need, we're able to provide those candidacy evaluations as well. So I wanted to transition a little bit now to a subfield called psycho-oncology. And whereas, social workers can intervene in a lot of the ways that I just went over, those are very practical things. But obviously, as we know, mental health is a huge, huge area of distress for our survivors and their family members. And so psycho-oncology is specifically focused on the mental health impacts of cancer, the disability that it causes, and then the resulting mental health diagnoses or just general poor coping that folks may experience. And as you probably know, a lot of these services can be provided by licensed clinical social workers or licensed clinical counselors, by psychologists, by psychiatrists. There's a lot of different disciplines who can provide these kinds of services. I just wanted to go a little bit deeper into some of the common mental health conditions experienced by cancer patients. Again, we have the adjustment disorder, depression, anxiety, what we call complicated or anticipatory grief if someone is facing their own mortality and is trying to work through what that means to them, and what legacy that they want to leave for their family and in the world. And then obviously if someone is experiencing suicidal ideation or in the terminally ill, we do definitely see a desire for hastened death. And so we want to try to sort of breathe back some meaning and some purpose into those final, 3, 6, 9 months of life, so that someone isn't feeling like they're just sitting around and sort of waiting to die. That's not how we want someone's experience at the end of life to be. So we can definitely provide some support around that. And then of course, folks have often a history of mental illness. And so we can see a lot of relapses or exacerbations of those things. And this is particularly salient when someone has serious mental illness that, perhaps they have well controlled at this point, or if they don't, we need to make sure that they can get into treatment for that. So things like PTSD, psychosis, bipolar disorder, manic episodes, a history of suicidal attempts, personality disorders, schizophrenia. These can be really, really challenging comorbidities for everybody to deal with who's involved in the situation. Certainly the survivor and their support system, but also, the medical teams, because a lot of these disorders can really impact someone's ability to understand and plan and then follow through with a lot of the treatment recommendations that may be life-saving. We do unfortunately see higher rates of, death among folks with serious mental illness. So we want to be really attentive to those things and intervene as soon as possible. And then again, just the general statistics, a reminder, approximately 30% of all cancer patients are going to have a mental health concern during or after treatment. But then depending on the population you're working with, double that essentially at UI Health is what we typically see. So these are some of the psycho-oncology services that we offer on the oncology social work team at UI Health. We can definitely do comprehensive mental health assessments, and that would include recommendations for things like inpatient psychiatric hospitalization, or recommend that someone seek the care of a psychiatrist for medication management. Certainly, we can make recommendations for community referrals for higher levels of care or specialized care that someone might have. There's sort of a common saying in the mental health world that trauma begets trauma, and trauma can, sort of cause past trauma to arise. And so we see that a lot with folks who have a history of traumatic experiences like sexual assault, childhood trauma, violence in the home, post-traumatic stress disorder from, whether they were a veteran or whether they experienced community violence and developed PTSD from that. If someone has not dealt with those things, all those feelings, all these complicated mental health symptoms are going to likely arise during the course of cancer treatment. And so they need to actually seek specialized care for those particular things that they're dealing with. We can provide comprehensive substance abuse disorder assessments for folks. I just wanted to remind people, in case they're not aware, UI Health actually does not have an inpatient medical detox program that is formally for that. And so we do typically have to refer patients out of our system for that. But there are a lot of really good options for substance abuse disorder treatment here in the Chicagoland area. So we can connect patients with those resources. We can do basic cognitive assessments for things like suspected dementia, decisional capacity, things like that, using tools like the MoCA or the MMSE. So we're able to do that, as well as many other disciplines are able to do that as well. Again, we can help connect folks with specialty oncology resources like support groups. A few of us, including myself, are trained in oncofertility counseling, which is especially salient for AYA patients, their families, their partners. Again, thinking about how these cancer treatments impact someone physically, it might involve removing some of their reproductive organs or being able to carry a child or all these different things. And so that can be a really significant thing that people need to think about immediately, which is really hard for folks to do if they're faced with, essentially their mortality. And so sometimes that can be pushed to the back burner, but we really want to make sure that folks are understanding the long-term impact of what they're about to go through and sort of help them think about that and get into that space. And then, whatever did happen during treatment, when they're in their survivorship phase post-treatment, helping them to think about when they do want to maybe start a family, what their options are, whether it is something like IVF or if that's not possible, adoption, all those different kinds of things that can impact someone's life. We're able to provide short-term individual psychotherapies here at UI Health in the oncology social work department. Some of the common kind of modalities that we use are cognitive behavioral therapy, acceptance commitment therapy, trauma-informed therapy. We do have someone who is certified in drug and alcohol counseling, and so we can sort of help to manage someone's comorbidity in that area. We definitely provide a lot of coping skills training, teaching people things like communicating their feelings, naming emotions. If someone's never had to do that before, that can be really revolutionary for them, just learning how to express their emotions, or stress management. I used to be able to remember everything, and now that I have cognitive impacts from treatment, I'm forgetting to do all these things like pick my kid up from school. How do we, in a very practical way, help you to, learn to write things down? So different ways that we can help people cope with the different impacts of their cancer treatment. And then certainly, as needed, we can involve the family in these counseling sessions, or the couple, or the caregiver as well. And these are the references. And then if anybody has any questions, I would be happy to take them at this point.
Wow. Thank you, Anna, so much for this talk and for keeping our eyes open to all the different psychosocial concerns that our cancer survivors have. I would venture to guess all of our cancer survivors have at least one, because like covered a huge breadth of different areas of concern. And I am always running into these with my patients. It's amazing where they turn up to. I had a patient who gets all of his nutrition through his G-tube, and that's affected his ability to work because he has to manage it every 2 hours. Mm-hmm. It's just so shocking how pervasive all of these issues are. And while you were talking, I was just thinking of how important it is to build a relationship and rapport and trust with these patients too, because I'll talk to many patients and sometimes it takes a little work to kind of dig out, oh yeah, they have trouble with transportation, or oh, I'm having trouble paying this bill. So it's really important to try to know the kind of signs and signals, and referring to social work. Do you recommend that us all as providers are implementing some of these screeners into our practice, or is there something that we can screen for to kind of know when to refer to you?
Great question. Yeah. And like I said, some patients are good about reporting these things, but a lot of patients actually feel some level of shame. They feel like they should be able to manage all these different things, when of course not. They've never had to go through this before. They don't have the resources that they need. And yeah, sometimes that can be a source of embarrassment for folks. So yes, it's always good to, even if you only have 5 minutes and you don't have 15 minutes to really implement like a formal tool, you can simply ask someone, are you experiencing any concerns in emotions or in your day-to-day lived experience? How has this impacted you? And, you can prepare yourself to maybe get a long-winded answer, or maybe not, but just inviting that conversation and, helping your patient know that this is something that you are interested in hearing about as a physician, as a nurse practitioner. Because, people think, okay, I'm not the doctor. I'm here to talk about my headache or my runny nose or the pain in my groin or whatever the case may be. So they don't always think that it's appropriate to share with their provider, how this is really impacting their life, their family, their job, all these different things. So just inviting that conversation is a great first step. And then certainly you can, implement some of the tools that I mentioned. But if you think someone needs an assessment and you don't have the time to do it, you can always refer them to the social worker to get that comprehensive assessment.
Right. And then conversely, providers aren't necessarily comfortable asking their patients, are you food secure? Are you getting enough, coverage for your medical bills? This is not a conversation that comes naturally to us either. And so it can be very, very tricky and very difficult. So again, thanks for keeping us all these things in mind. I know Dr. Ganshow asked in the chat, are we doing any type of universal screening for social determinants of health in oncology or at UIH?
Yep. So we do have a formal distress screening program. Again, I mentioned that we use the Coleman comprehensive screening tool, which actually includes not only screening elements for social work, like it has the PHQ-4, it has a list of common social determinants of health drawn from the NCCN distress thermometer, but it also includes measures for someone's nutritional status, for their spiritual status. There's a whole list of different common physical side effects of treatment. There's a measure on there for palliative care, for PT/OT needs. So it's a very comprehensive tool, and it's actually built into Epic. And so if you do want to use that, you are certainly welcome to. But yes, that is something that the social workers use on a regular basis to assess patients for distress. We are working on expanding that because with the pandemic, it has been disrupted and changes in the team. And we want to make sure that everyone has more access to that.
Right.
Certainly every time you refer a patient to social work, we're doing this comprehensive assessment. So it doesn't always have to be, that's how someone obtains a referral to social work. But certainly for folks who maybe are just less inclined to share those things, giving them boxes to check can really be a useful thing.
I know there's sometimes a little disconnect between UIH and Miles Square. I don't know if you know if this is happening at Miles Square or if this is something that we can kind of unify to bring that screening to all our patients.
I would tend to think that unless someone has been trained or is hired to do this, probably it's not happening in a formal capacity, using the Coleman distress screener at the Miles Square site. Right. I think that's a really great opportunity for growth for us as a system. And it probably would involve, hiring a social worker or someone else who is similarly trained to be able to make sure that new patients who are coming for second opinion or transferring care, all these different points of entry are receiving screening. So yeah, that would be, I think, a great quality improvement project for our program.
Yeah, I know there are social workers at Miles Square, but they can learn a lot from, what UIH is doing, what oncology is doing to be screening all the patients for distress. So I can definitely reach out to and talk to social workers there. Other than that, most people were just saying, thank you for all the information, Anna. And this was a really great talk. Does anyone else have any other questions or comments? You can unmute and ask. Thanks, Candace, one of our cancer survivors, for showing up. And do you have anything to say, Candace, on this matter? All right. Well, it's almost 10 o'clock. Thanks again so much, Anna. And this is going to be, it's recorded, so I will post it and send everyone out the link. Thanks everyone for coming and have a great rest of your week.
Bye, thank you.